your hepatology broadcast news live from the International Liver Congress. I'm Virginia Hernández-Gea, and it's my pleasure to be here with Eric Trépo, Luca Valenti, Lleo, and Aleksander Krag. So, Aleksander, maybe we can start with you. How was your day today?
Oh, thanks a lot. I think it was a great day, or another great day. I still think that there are many successes I think we can celebrate here, being together, but also I think the atmosphere. The first day was really super exciting, but the tension really continues to be there, and I just feel so privileged being part of this. Every time I see a full room, and every time, I know it's a little disappointing, but there's so many questions that we cannot really take them all. So this way of really celebrating. But also in my position here as Vice Secretary, we do a lot of more things than just enjoying the science, also many meetings, and yeah, I just can pick on a few of them, but we had a very nice meeting. As you know, part of what EASL really is striving to continuously do is really being the home of hepatology, but also uniting hepatology. And one of the things we're doing is really trying to collaborate very close with the national society throughout Europe, and we had now today 17 societies in one room discussing exactly what can EASL do for them, because we all want the same. The mission, the vision of where we're going in terms of improving knowledge, awareness, care, science for liver is all a shared vision. So how do we work together? How can we actually help them, and how can they also support EASL? So that was really all this enthusiasm, all these people that want to go in the same direction. And one special thing was we had also 2 representatives from the Ukrainian Society for the Study of the Liver. Again, fantastic. We've ourselves strive quite hard to get them here. First they went from Kiev, a bus to Poland, and then in here. Not exactly an easy start. Yes,
not easy, but it's good.
Beautiful. I could spend the whole evening here telling stories, but maybe you can come back to me later. But definitely some of the highlights from today.
Sounds very good. Anna, what about you? What are the highlights of your day?
Well, there were 2 things I really enjoyed a lot. First, we did very short and informal presentation of one of the consortia that is endorsed by EASL. Mm-hmm. Is the European Network for the Study of Cholangiocarcinoma, and it was really good explaining to people that just stopped by how the consortia was built, what the endorsement from EASL means, and the activities that are currently ongoing. Some people actually showed very interest in collaborating, and they sign up left a rim. Yeah, so that's been really interesting. And I liked also the presentations on the guidelines. Really, I think it helps. It highlights, the main aspects. Even if it's not your field of expertise, at least you bring home the main messages, and it gives you also more interest to go and read the whole paper. And I think that was very useful.
Clear messages.
The most novel aspects in your field.
So today the primary sclerosing cholangitis guidelines were presented, and so there is a whole new chapter on surveillance in cholangiocarcinoma, and that's been addressed by the experts, and I think it's a key point because there is a high risk for cancer, but we don't have a lot of solid data on the efficacy and the tool to use for surveillance in these patients. Is MRI the best one? So that was a very nice discussion.
Good, great. We also have today the late breakers abstracts, which was one of the very well attended sessions. Luca, can you comment on any of the relevant news that we got today?
Well, absolutely. There were a lot of very interesting presentations in the session covering the whole spectrum of liver diseases, from viral hepatitis to non-alcoholic steatohepatitis, HBV and in particular, and basic science as well, genetics of liver disease, with a study highlighting novel locus, for example, for liver cancer related to alcohol abuse, and a new mechanism of liver damage, the role of necroptosis and steatohepatitis. So my field is more related to metabolic liver disease, so I listen particularly the new data related to one of the most promising classes of drugs, the thyroid receptor beta agonism, the resmetirom study in fatty liver disease, and the data were in line with those presented in previous studies, confirming that this may be actually one of the potentially successful strategies to cure the disease by decreasing hepatic fat accumulation. The study confirmed the drug was safe, and it was able to reduce non-invasive biomarkers of liver damage. But of course, also the new data on genetics I was also very excited about, and being one of the collaborators in my main field of interest. So Enrique, I know you are also very interested in genetics of liver disease, so what's your take on the study and the novelties in the field?
Thank you, Luca. I think it was very nice study. You know, it's you were part of the study, so you know it very well. But what is very nice, it's first it addressed a major burden for liver disease, which is HEC, and it was alcohol-related HEC because HEC, you know, you hear that NASH is contributing a lot, but Aleksander, I'm sure you will agree with me that alcohol is still a major driver for HEC. And here, what they have done is they had a lot of cases in control, so they did what we call GWAS, which is the easiest way to look for like genetic variants that are associated with the disease. And they were able to capture the usual folks, so PNPLA3, TM6F2, and they found a new locus, which is in TERT. So for the people that are involved in HEC, people know that TERT is really the first gene that is going to be mutated, is going to accumulate somatic mutation, and here they find a germline variant. And here it was protective, but depends at which allele you're looking at. So it was very nice because it also makes sense with the pathophysiology of the disease, because with this type of study, sometimes you capture things that are difficult to link with HEC. So it's important. It shows that I mean, the concept is nice. Obviously, they will need more patients, more power, and then they're probably going to find more and more genes. So it was very nice indeed.
And we will hope to translate sooner or later these new discoveries into new drugs or a better way to manage the patients.
Certainly, new drugs. Probably not prediction at the moment because we don't have enough loci. But for drugs, yes, I think it has been proven in the past in other fields. For example, coronary heart disease, and for hepatology, I think there's a huge potential there, but they will need more functionality, all these kind of studies that are, that should be ongoing now.
What do you see a future for silencing drugs? So what kind of drugs are relevant there? Because I think I was really fascinated that genetics has been around for so long. There's been done so many studies, but still, the more power we get, and the more we come up with new loci, and I think this was really surprising that this was really seems to be associated with significantly lower risk of HEC. Yeah.
Well, I think the potential is huge, but at the moment in hepatology we are suffering from one thing, is that the sample size is quite low compared to other fields, diabetes, Alzheimer, heart disease. So I think when we're going to have really the power and all the samples, because Luca is going to agree, it's something that is, genetics in liver disease is not something that is so old, that now we are really building consortium and things like this. So I think... So
why is that? Because there are 7,000 people here. Why can't they find the patient? This must be the perfect place to set up a big consortium, because I guess that's the way it works with these meta-analysis and stuff.
Indeed. It's a good question, Aleksander. My view is that it's only going to work if we sit together and we put all the, we join forces and we do indeed this big meta-analysis. I think one of the reasons is that it's still new, so people are not used to it compared to IBD, for example. In IBD, they have been doing this for years and years. And we started a bit late, but we are catching up. But for sure, consortium will have to be built, and people will have to, let's say, again, yes, put their force together.
That study was also actually with patients from many different consortia, wasn't it? Luca, you were part of it, or you maybe...
Yeah, I don't know if it's many consortium, it's many teams for sure, because HEC is it's common, but it's not also so common. So you still need many centers to reach sufficient number of cases, and so that is very common in the field of genetics. You have these papers where you have 70, 80 authors, and maybe 7 first core first author, and the same for the last authors. It's also what is also beautiful is that you can really add a lot of people, and really acknowledge the contribution of a lot of people.
Yeah. And then rake really good stuff. So that's I think it's a beautiful way of really coming a lot of people together and making something that's difficult but really useful clinically also. Yeah.
Indeed, but it's an association. Then it's really epidemiology. You just call it genetic epidemiology. As always, when it's epidemiology, you have an association. Then you have to prove it. So I think it's the first part, and then you really give let's say your results to the people that are really doing basic science, and they can really prove that it's something that is causal or not. So I think it's a great collaboration. It's very nice.
Yeah, absolutely. So
maybe I can ask. I'm so curious, Luca, because the big field here is NAFL, NASH, and so much are happening. And then there was 2 big trials in NASH. So what do you make out of it? There was a semaglutide. Was it a phase 2? And where do we go from here? Because that seems to be the big thing for Novo these days. So what's the bottom line of the semaglutide study there?
So I think semaglutide was confirmed to be safe, even from the data presented today in patients with cirrhosis, which was kind of needing a confirmation, and was effective in reducing weight on average of the patients, and some markers of metabolic alteration associated with weight. And so there is potential there that the drug will also be able to induce some benefit in the long term in patients also with advanced liver disease. I think this is important also because this is one of the drugs that's already currently in use for patients with type 2 diabetes and obesity as well, so it's important.
Now the trials are starting also in cirrhotic patients, so really not just the fibrosis.
Yeah, I think that it was important to demonstrate it's also safe in cirrhotics because this will be facilitate the prescription, for example, the drugs in diabetic patients with cirrhosis without, for example, worrying about potential side effects related to the liver, by showing that it's potentially already also beneficial in this subset of patients. So I think this was an important step in the development program of this drug and this class of drugs, because we know that we have several drugs that are targeting GLP-1 and GLP-1 now. We have very exciting data last week.
Do you know if they will start then, or maybe already done, starting a phase 3 trial in cirrhosis, or because they're having a phase 3 in F2 and F3? Yeah.
Does it make sense? Does it make sense to start at phase 3 in cirrhosis? Because as far as I know, it was like, okay, it's safe, but it's negative.
Yeah, I don't know. How do you take it? Because was it a sample that it was p-value of 0.8 or something?
Indeed.
So and how many patients were there? I can't recall. It was not a big trial, so it could be a power problem. I don't know. What do you think? Yeah.
I don't think it's a power problem, so it depends to which endpoint you're looking at, if it was resolution of NASH or if it was, the reduction of fibrosis. For the reduction of fibrosis, I think, as you said, the p-value was 0.8 or 0.8-ish, something like this. So I don't think it was very encouraging there. But on the other hand, But
then would you expect semaglutide to reduce fibrosis? Or because I know they are running this phase 2 trial where they combine it with FGF21 to have a more fibrotic target, both and cover the metabolic component and the fibrotic. I don't know.
Yeah, no, I think we need to focus on, since the patient is already cirrhotic, is progression of disease and outcomes, solid outcomes in terms of survival and complications. The problem is that takes time, but I do not expect a drug like that to reduce cirrhosis. The aim could be to stop the progression.
Yeah, I think that the most important outcome in patients with cirrhosis that are at risk of complication is the prevention of the rate of complications, and requiring probably longer trial. But if this is a drug that is currently already in use with some other indication, it's very important to prove that it is safe also in this category of patients. And if it's safe, it will also lead to the same benefit. We can continue to develop this drug.
But you're right, but this is the point, because I'm not sure we are aware of any drugs that can reverse cirrhosis. I don't think that it exists, so that was indeed not the point. But for resolution of NASH, you had a nice trend, but what is important, you're right, Luca, is that we want this patient not to have to decompensate.
But Eric, don't you think that's a time problem also? Because imagine how many patients you catch with when you have them with their diagnosis of autoimmune hepatitis. Many of these older kids, they have cirrhosis, and then you treat them, and years down the road, then the livers are normal. And also some of those you see with relatively advanced alcohol-related liver disease, then they stop and improve a lot. So it could be because I think the regenerative potential and potential also the drug across many liver diseases would be able to reverse. I don't know.
Well, removing the cause of disease has always been proven efficacy. If you think about virus, if you think about alcohol, if you remove the pathogen or the toxin, indeed the disease improves. So in the end, I don't see why NASH should be different in the end.
In the long term.
In the long term, yeah, of course, in terms of complications.
If you remove the trigger, you should be able to...
It would have been amazing if it would have worked. So you would have a patient that is cirrhotic, and you can imagine that then he's F3 or F2. That would have been absolutely fantastic. And I agree that autoimmune hepatitis is a good example, because sometimes you have these patients that are indeed cirrhotic, and then they are treated after 3, 4, 5 years, and then sometimes they regress. It's true.
Yeah, speaking about autoimmune hepatitis, there were some very good presentations at the abstract session upstairs. I have to say that I'm happy to see that the field is always more populated. You know, years ago it was like small rooms, 20 people, always the same. And now there is a lot of interest. So that was nice, and good studies.
I missed that. Are there one or two you can tell me about?
Yeah, well, I have a conflict of interest because one is from my group.
I think that's perfectly fine if it's a good one.
So I think so. So this is a multicentric study. We run it, but it's actually thanks to all the collaborators of the International Autoimmune Hepatitis Study Group, and we wanted to see the incidence of HCC in these patients. So far we have 1,400 patients involved.
Wow.
And actually, the incidence of HCC is very, very low. Really low.
How low? Well,
how low is like in the overall cohort is 0.7 at 10 years percent. 0.7% at 10 years.
Oh, and how advanced disease group?
And this is the whole cohort. If you look at the cirrhotic patients, it goes up to 3% at 10 years, but it's 0.3% per year. Yeah. So it's very, very low.
Would you screen these patients?
That's the point. That's the whole point. Nowadays, we surveil them as any other etiology, but probably it's not cost effective if this is confirmed. Of course, it's a retrospective cohort, but the good thing is that the follow-up is very, very long. We go up to 35 years of follow-up.
Now, this is really interesting, like many other things, but are there any then differences? I could imagine that those who are well controlled and respond well to drugs, they must have a lower risk than those where we have difficulties and they...
Absolutely. I know this is the main point. So we didn't see any difference in the type of treatment, so immunosuppression does not make any difference. I mean, the drug you use for immunosuppression. In terms of response, we see that the responders have lower rates of cirrhosis, so you would expect to have less HCC. The thing is that the numbers are so small that the difference is not significant. The other difficulty is that in such a long follow-up, it's difficult to establish the time of response. So what do you choose? At 1 year, at 2 years? It's a little difficult, but...
so the bottom line is basically that we shouldn't be that worried, and can also tell our patients that even though we make surveillance, it's probably not the thing that just you worry
probably
so much
what makes the difference are comorbidities. Like we've seen that obese patients with autoimmune hepatitis do make more HCC. So comorbidities are key. Some patients probably still deserve surveillance because of other cofactors. Well, the work's still ongoing, so we need to see when we finalize all the data collection. But I think it's a strong message, and it's important to to let people know and the patients know, because it's a disease, it's a chronic disease. They often start very young. They have their whole life ahead, and knowing that HCC is not such a big
it's definitely
risk is important for them.
Clinic medical.
Yeah.
Yeah.
What about you, Eugenia?
So I enjoy a lot, the clinical board. It was one on portal vein thrombosis in the afternoon that was like very identifying the controversies in the clinical management of portal hypertension in cirrhosis.
So which session was that?
It was in the pathology arena, the clinical, the board, clinical board on the management of PVT. It was very well attended and very interactive. So people was like asking those difficult questions about the management, and it was like a lot of discussion, and I found the format and the type of interaction very, very interesting, and I think that people got like important messages for the clinical practice that I think this is also something that is searched by our community.
Where's the field moving now? Which one is it's something about anticoagulation or not, or on when and in who?
No, I think that it's like what we're starting to see is that probably the thrombosis in the splanchnic territory is something different, because it's very interesting when you treat them with anticoagulation, something that never happened in the other territories, like in the legs or in the lung, where usually you achieve recanalization very quickly. It does not happen in the splanchnic territory, and even 60% of our patients, they do not recanalize. So what opened the question is like, is this a real thrombosis? What are the pathophysiological mechanisms implicated? And what should we do with them? Are we anticoagulating patients, but maybe we are exposing them to a risk and it's not necessary? So I think that this is opening the field to new hypotheses, and of course it's not easy to study the portal vein endothelium because it's something not so available. But I think that this is where the studies will go.
How is that? Can I really come up with a smart studies design there?
No, I think that we really need to understand the mechanism and what it's driving the disease and why it's happening, and then designing like better studies.
Do we need to anticoagulate the patient with PVT that have lower than 50,000 platelets or not? Can we anticoagulate these patients?
I think we can anticoagulate these patients if you have a thrombosis that really needs the treatment, but I would recommend to start with low doses, and then you see how things go, and you titrate the doses quickly. But I wouldn't exclude them just because...
Even which anticoagulant would you use then, Rina?
This is another controversy. I think that we need more data to be more...
What do you use?
Low molecular heparin at the beginning, and if the patients, and then you switch to vitamin K antagonist. I think that if the patient has preserved liver function, we have more and more data demonstrating that DOACs are safe.
You know directly. So you first start with HBPM, and then you move to...
first with low molecular heparin, and then you change.
Okay.
And what about... felt comfortable with DOACs in child A?
Child A, child B, I think that we have enough data to be
it's so much easier, basically.
Yeah. Yes.
It makes a huge difference.
The problem is that I don't know in your countries, but at least in Spain, it's difficult to get the indication because it's not recommended for this kind of splanchnic vein thrombosis. So it's complicated, and it's not covered by our health, social security insurance. So we also need data to change this, because I think that they have like really advantages over the other options.
What about the timing? Would you anticoagulate also patients for whom you don't have a proof that the thrombosis is recent, or?
I think that the message here is that I would not treat an image only. So I would treat if the thrombosis is giving symptoms or if the patient is a liver transplant candidate, that you can risk the future anastomosis, and this is something that it's the aim of the treatment. It's like if you discover a portal vein thrombosis before starting treatment, you should define why are you treating the patient and what is the goal.
So if you know that the patient is not going to be transplanted at any time, so excluded from the waiting list, you would not anticoagulate the patient?
If it's asymptomatic and it's not a candidate for liver transplant, I think we do not have data to recommend anticoagulation in this subgroup.
Despite the time range, like if you know it's a very recent thrombosis, you don't coagulate?
If it's a small thrombosis, asymptomatic, non-liver transplant candidate, I would not recommend.
It's becoming very clear that it's not so easy.
But again, it was good to speak about all these controversies.
But there I think also about what we talked about, how do we make good research for really rare things. There I think really the vascular liver field, imagine where that was 10 years ago. For Valenti, really, some of these consortia really came together, we knew almost nothing. And that was really what advanced that field. There was a researcher from all over Europe who joined forces and added it in, and then we learned so much in all these years. So again, a beautiful example of why it's really important is to collaborate. But Marina, shouldn't we tell or celebrate the new members of the EASL governing board? Tonight we have two who was on job for the first time. So we have Lleo and Eric Trépo was yesterday Trépo, sorry, was yesterday elected by the General Assembly as the new governing board member. So a warm welcome. We look very much forward to working with you, and it's good that we can put you to work already for the first day. And Luca, you together with Manoli Tsotsakis stepping down. We're gonna miss you.
Thanks.
I don't know what you will use all this time for, but no, this is a great shift and opportunity.
Thank you. We felt very welcome, I think. It was nice.
Indeed. We're looking forward to it. I guess I can speak in your name here.
Yeah.
So a key responsibility for being in the scientific committee is to make and be responsible for ILC. So now a key task for you is really to try to beat what the current committee have done this year.
It's going to be difficult.
It's going to be difficult, yeah. And
we come to you, I mean...
Yeah. And maybe also I can say another thing, which I think now thinking about the General Assembly, and to be honest, it was a little late when it ended, and I think the final thing many may have missed, but I think a very important thing we also decided upon was a new membership strategy, that we believe that the potential for EASL to have much more members. We have 30,000 MyEASL users and 1.2 million click views on EASL campus. And then how do you attract new people? Yeah, you make it very attractive and very cheap. So it's also for everybody listening and who are non-members that a barrier to some have been the price. So now we've halved the fee for young investigators, postdocs, or people in training, nurses also, allied health care professionals, patients, very low. And for low-income countries, we've made it completely free because we think that these countries really can benefit for, and there the price is definitely a barrier, but all the material, everything EASL stands for, delivers, should come to these countries and benefit their societies and patients. And middle-income countries, I think we ended up with a price of 25 euros, still relatively low, so please spread the news. People are most welcome in the EASL family. Yeah. And then on the other hand, then we tighten a little bit, that many of the things that today has been sort of the free access will then going forward not to the same extent be free access. Things on EASL campus, access to convention content will then be for members or delegates only. So that's the bargain. When you open the one door, you need to tighten another one a little bit.
Sure. Mm-hmm. Yeah, but in the end, more and more people will be able to benefit from the EASL membership. So I think overall, and we'll have a lot of new services and benefits for our new members.
It will help for young investigators as well, I think, to
So
encourage them.
We're really looking forward to it. And
Yeah, and I think this year we had 550 delegates registered as young investigators. So we also really nice to be the place for the next generation, really, where they learn, train, get their network.
well, it's been very fruitful and interesting discussion and a recap of the day. Thanks, Aleksander, Anna, Eric, and Virginia. So we should close today, but tune in tomorrow for the EASL studio farewell, live from International Liver Congress 2022 for a farewell from our secretary and vice secretary to you. Bye.
Bye, thank you.
Thank you.